Hi, my name is Vicki Smith, and today we're going to be talking about the cardiovascular changes in the geriatric patient. At the end of this presentation, the learner should be able to verbalize age-related anatomic changes to the heart, identify the physiologic changes in the geriatric population, describe possible alterations observed in the physical assessment of these patients, and develop patient education strategies. The anatomical changes that you'll find in the cardiac area will be that the heart will actually increase in weight and size. Calcium uptake prevents myocardial relaxation. And the heart's a muscle just like any other muscle. So when there are periods of unrest or the heart or any muscle is in a constant state of flexion, that muscle will increase just as with the muscles in your arms, your legs, etc. The ventricles will stiffen. The left atrium will dilate and hypertrophy. As the left ventricle wall thickens, less area is available for blood collection, so this will lead to decreased cardiac output. The left ventricular wall thickens. This will predispose your patient to atrial fibrillation. And the endocardium, myocardium, and the valves will thicken and calcify. Again, this will lead to decreased ejection fraction, which signifies a diminished cardiac output. The physiologic changes that occur in the heart, so slowed conduction at the SA and AV nodes. This is due to hypertrophy of the myocytes, or the muscle cells, and the calcium deposits that occur over time. There's a 10% loss of the sinus pacemaker function. This is caused from degenerative changes. And about 90% of patients over the age of 75 will be diagnosed with a sick sinus syndrome. This is because the SA pacemaker cells lose the ability to initiate electrical impulses. So what intervention is likely to occur in this age group is a pacemaker placement. And there's increased incidence of bundle branch blocks. Again, this is due to calcification deposits blocking that electrical impulse. The systemic effects of the aging cardiac muscle is a decreased activity intolerance. Maximum oxygen consumption declines with advancing age due to the decline in the maximum heart rate and cardiac output. Maximum heart rates in the geriatric population, there's been a rule of thumb that 220 minus the patient's age will give you the maximum heart rate that can be tolerated. So a lot of the cardiovascular exercises for the younger adults, they really want your heart rate to get to 160. With the older population, the geriatric population, a lot of times this rate can't get over 120 or 130. Sorry. There's more frequent syncopal episodes related to orthostatic hypotension, poor responsiveness to medication interventions to adjust changes in cerebral blood flow can lead to the syncope and an increase in falls. So it is a patient safety factor. Diminished response and rapid medication intervention for blood pressure, heart rate, and cardiac output is delayed. Not only do the patients in the geriatric population metabolize medications slower, but the heart reacts slower to these medications. So be careful not to, be careful of multiple dosing in these situations. A lot of times you may be in an emergent situation and you have a patient who receives, say, IV push hydralazine, and there's not a response rate. Just as if with renal dosing, you should have geriatric dosing with a time element in there, reassess in 10 minutes instead of the 3 or 4 or 5 minutes that normally you'll see on an acute care floor. Sometimes you'll get a collective action that your patient will go from a hypertensive crisis or episode to a hypotensive crisis. Arteriosclerosis and coronary artery disease are very common in the geriatric population. And assessment reviews, things that you may find when you do assess your patient. It's a heart murmur. A swooshing sound. It's very obvious when you hear a heart murmur, but that's your valvular defects. Thready and unequal pulses, again, that's from a diminished cardiac output. You'll get a slower heart rate. Again, this is from degenerative changes in the sinus node. You have a diminished intrinsic pacemaker setting, so to speak, or a response. You'll have patients with a complaint of chest pain or angina. This is from a reduced temporary flow of blood to the cardiac muscle, so you've got some ischemia going on at that moment. Shortness of breath or dyspnea. Reduced capability of oxygen-rich carrying red blood cells because of a low volume will lead to diminished cardiac output. Again, you don't have enough oxygenation, so the patient will have some dyspnea, shortness of breath with exertion. Varicose veins and a history of CVA or TIA. The varicose veins are actually from atherosclerosis, which is a thickening of the arterial wall. A lot of times this is genetic. Sometimes it can be environmental as far, well, actually exercise, health factors. And a history of CVA or TIA, and this is a side effect or a result of hyperlipidemia. So you'll see some patients on the statins. So the varicose veins is from the thickening, the atherosclerosis. So a TH for thickening, and CVA, TIA from arteriosclerosis. Patient education. So what can we teach our patients to protect their health, to maintain their current state of health, or to prevent a decline in their health? First of all, quit smoking. Smoking constricts your blood vessels. It elevates your blood pressure. Eat healthy. Reduce the intake of saturated fats and cholesterol. There again, preventing or reversing arteriosclerotic side effects. Lose weight. Central obesity is the #1 precursor to diabetes and high blood pressure or heart disease. Control your diabetes, your blood pressure, and your lipids. They have what is being more prominent as far as a medical literature of the metabolic syndrome. This is when you have the 3, diabetes, blood pressure, and lipids, and it's a cycle. The cycle is run by hormones, so it's all hormone control, and it is in male and female population, but since it is hormone controlled, when you have a female who is also in this stage of menopause or postmenopause, you just add another element to that cycle. So what can be controlled definitely needs to be controlled. Exercise, again, moderate exercise to increase that heart rate. The heart rate's already low, so more activity may be required to get it up into a cardiovascular area. So just kind of strolling around the house won't quite get it. We're going to have to get our patients up and get them moving. And that is all that I have. Any questions? Thank you very much.